Hello and welcome back to GastroVision. I am Dr. Qazi Suhail. Today we are tackling one of the most dramatic situations in hepatology, acute liver failure, and a therapy that's both fascinating and controversial. Therapeutic Plasma Exchange. We will explore what it is, how it works, and the big trials like Burke et al. And expert insights from Lal and Alam, and yes, the different types of plasma exchange, and whether the technology itself changes outcomes. So first, what's acute liver failure? Acute liver failure is one of the medicine's true emergencies. A previously healthy liver suddenly collapses, patient develops jaundice, coagulopathy and encephalopathy, sometimes within days. Mortality risk is very high unless transplantation is possible. But here is the catch. Not everyone gets a transplant. So, can we buy time? Can we give the liver a fighting chance? That's where therapeutic plasma exchange steps in. Now, how this plasma exchange works? Think of plasma exchange as a detox and recharge system. We take blood out, spin and filter it, remove the plasma and replace it with fresh donor plasma or albumin. What does this do? It flushes out toxins, ammonia and inflammatory mediators. It calms the cytokine storm. It restores clotting factors and it can stabilize blood pressure and hemodynamics. In theory, it gives the injured liver precious time to regenerate or bridges the patient to transplant. Now, coming to the randomizer trial, looked promising. High volume plasma exchange, improved labs, lowered ammonia, and even improved transplant free survival in some patients. But then came the Burke et al. Multicenter UK cohort, their real world data from 378 patients. What did they find? They found plasma exchange improved hemodynamics. Vasopressor requirements went down, but overall survival, no significant benefit. Transplant free survival, also no improvement. So great physiology, but survival wasn't changed in unselected real world patients. Why this discrepancy? This is where Lal and Alam step in with their 2025 review. They asked why the gap between trials and practice, and they highlighted six big challenges. ALF is not one disease. Different causes behave differently. Timing is critical. Too late and plasma exchange can't reverse the spiral. No protocol consensus, volume, number of sessions, still debated. In low resource centers, delays are common. Prognosis is unclear. No biomarker tells who will benefit. And transplant integration, is it a bridge or a definitive therapy? In short, it's not just about doing plasma exchange, it's about who, when, and how. Now, what are the types of plasma exchange? Does the method matter? Not all plasma exchange is the same. The technology matters. One is centrifugal plasma exchange. It uses a centrifuge to spin blood and separate plasma. It's efficient and processes large volumes. This is the method with the strongest evidence in acute liver failure. Another is membrane plasma exchange. It uses a filter, often on dialysis machines. It is more accessible, especially in hospitals with dialysis units, but it usually clears smaller volumes, and filters can clog in high bilirubin states, maybe less powerful in acute liver failure. Next is double filtration plasmapheresis. Two filters, one to separate plasma, another to selectively remove big molecules. Great in autoimmune diseases or lipid disorders. It has a limited role in acute liver failure. Next is adsorption systems like Mars, Prometheus. Plasma or blood runs through special columns that grab bilirubin, cytokines, and toxins. It is very expensive and not widely available. It's more experimental in acute liver failure than routine. Let's recap the pearls. Plasma exchange works by clearing toxins and restoring clotting factors. Burke et al. Showed it improves physiology but not survival in all patients. Lal and Alam remind us patient selection and timing are everything. Centrifugal high volume plasma exchange has the strongest evidence. Membrane plasma exchange is accessible but may be less effective. So, start early, don't wait until multi organ failure. Always integrate plasma exchange decisions with the transplant planning. So, is plasma exchange the magic bullet for acute liver failure? Not yet, but it can be a powerful bridge therapy if you choose the right patient, use the right technique, and start at the right time. Centrifugal high volume exchange leads the pack. Membrane exchange is useful where resources are limited and adsorption systems are still the future. Unless we refine protocols, plasma exchange will stay as a supportive hero, valuable but not the final cure. I'm Dr. Qazi Suhail. If you learned something today, hit like, share. See you in the next video.